Okay, so let's touch upon a topic which I think is important for everybody. You do adult cataract surgery at the age of say 60, 65, 70. If he's lucky, he might touch 100, become a century, if he's lucky. So you got what you investing your energy and things for people who are going to live for next 30, 40 years, right? Here, the kids are with you from say 1 month, 1 year, 10 years. They're going to live 80 years. So please invest wisely in picking up your machines and your surgical skills. And pediatric cataract on the rise. So this is what you see. If you see the epidemiology, so it's counted in 10,000 units. So 1 to 15 in 10,000 live births is what you have these visual impairments, and blindness in this is 1 to 4 in the developed countries, the Western ones. And the developing countries, it's 5-folds more, right? So there's more than 1 million children are blind in Asia because of pediatric cataract, which is totally operable disease. And 200,000 are bilaterally blind because of cataract. Okay, so before I go there, the problem is, whenever the patient comes to you, the first thing the parent asks, the child having a cataract never heard of, because it's supposed to be disease for the senile, old age. So the parents have to be taught about the disease. That's the most important, because the follow-ups, the compliance for occlusion, the glasses usage, and recurrent change of glasses on timely intervals, I think that's the cornerstone for the treatment in these patients if you really want to manage this patient. If the patients don't want to wear glasses later on, you left the patient faking, it's as good as a blind patient. So the parents and the teachers in the school are to be taught and explain that this child should be allowed to sit in the front row in case he's not able to manage, and we try to give them the aids so that they can cover up very well. The unilateral cataracts will need patching majority of the time. When they come to us at the age of 6 months, 1 year, one eye has been good since birth, the other one is not seeing at all, maybe a deviation or sensory deprivation, and they need occlusion. So you have to be very careful what you do, and the parents have to be taught and sensitized about that. So basically, it's more important about teaching the parents about the disease and how they'll manage the child, because they're going to manage, not us. We'll just do the surgery and let the patient go back home. Okay, the parents come with one child and they got a big family. Please call all of the kids, and you'll be surprised at how you pick up. If you keep seeing all the parents, especially the mothers, if the mother is having spots, specks in the eye, or maybe a zonular cataract, it could be a Nance-Horan syndrome, which is coming by the X linked, and the male is involved, the females are not involved. So you can pick up a pattern and follow what is happening in this patient. All the sibling has to be seen, and I see these patients only one promise. I see the child that the parents will sit there for 15 minutes and have a tropicamide drop put in all 4 eyes, 2 for mother and 2 for the father. Give them 15 minutes and do a distant direct, put in the slit lamp. You'll be surprised to see the findings, right? You might pick up mitten dots which are there in the eye, which are not significant, but you get findings. So whatever you look for, you normally get it. So be alert. And it's not a one window. Adult cataract comes to you for surgery, you do a surgery, you do a phaco, you do a sutureless surgery, put a multifocal. He'll pay up front and go back home, will never come back to you till he has a VO or some other surprise injury or not. Here, the problem actually starts after the surgery, because you're not giving the zero power refractive errors, you're giving refractive errors to these patients so they can grow out later on into this power. So that becomes very, very important for us. Second, so resurgeries might be required. If you're handling the unilateral cataract, don't commit yourself that it'll be one surgery. Even for the bilateral, you might have a VO formation despite doing all the techniques which we'll be teaching you right now. So you can never be 100% sure which is the eye in which the excess will stay clear 100%, and there are none. So any of these patients can go into opacification. Okay, so they have to use glasses now forever, at least for life, or till they become adult and their number becomes stable. Then you can do whatever bifocal, this thing on the surface, contact lens, whatever you want to try, but till they become adults, it's your responsibility to follow this patient and keep following them up properly. So as you know, it starts very early. Before even the mother knows that she's expecting, she might have the lens which has started forming in the eye. So lots of time you see it's maybe it's a smoker, or the family is having drinks. So it can cause, but nobody knows about sure why it happens. We're still having lots of congenital cataracts, but this is how it goes. I think we all know about the embryology. If you see the data all across the globe, there's no country which is not having pediatric cataract. United States earlier was having very less, say about 2.03 in 10,000, but now with the migratory population, people coming from Mexico, India, Pakistan, Sri Lanka, they're all going there. Of course, you haven't changed their genetic formation, so if they're prone for cataracts, they'll definitely have one. Even there's a study in Australia, they found 2.2 per 10,000. India, we have about 45. We did the study at the RP center where we belong to. We picked up this patient in which we saw the lenticular abnormalities in the lens clinic. It was a huge data. And we realized that this is what we're getting. We're getting developmental cataracts in about 45% of patients. 30% patients of these were traumatic cataract. We put them in a different category because these are again avoidable injuries. In USA, 4th of July, they have fireworks, maybe more than what we use in India, but they are all controlled. I mean, there's a park, people sit at the back, enjoying themselves. In India, everybody can buy on the street, and the kids are playing and throwing it on each other, and that's what we get. And Eric, I mean, that's the problem we have. I mean, we're getting unilateral blinds a lot because of this trauma. And the last number 10 is a visual excess opacification. That means you've done the surgery, somebody's done the surgery, he hasn't taken care of the posterior capsule or a vitrectomy, and still there's opaque media. So it doesn't help anybody. Till the light goes into the retina, it's not going to stimulate the retina. So we need to have a media open. So these are the things which one should know. So with this, Vision 2020 has this, WHO has this in the right, it's the right for the child. So one blind child is equivalent to restoring vision of the 10 adult cataracts. That's what this says. So if you do an adult, pediatric versus geriatrics, ease of surgery for pediatric surgeon, I think he's happier doing a pediatric more than the adult ones. And the reverse might not be true. A great successful adult cataract surgeon might not be a good pediatric surgeon because you need to do a posterior excess, which we'll be talking about. Putting the lens techniques are different. So everything is a different ball game altogether. So